Good evening, everyone. So today, I hope many of us audible hai.
Yes, sir, audible.
Okay, fine. So today was the Taslim class, but due to his health reason, he is not able to take class. So I would be basically only discussing about the retinoscopy, the basics, very basics of retinoscopy. So these would be the objective of this class. So process of ametropia, so that would be very short, and review of basics of objective and subjective refraction that we had already discussed in last two class. So that just an overview. And how can we like when we do refraction, there are certain situation where we are doubtful. So how can reduce that confusion situation? And there would be some questions from the trainees, so that I would be taking in the end. So first, development of ametropia. So the way, so we know that whenever a child is born, a normal child, a healthy child, so normally they would be born with a hyperopia, and then after the process of emetropization happen, and then they gradually shift to emetropia. So if we see the whole span of a human being, so it can be divided into the four category in the terms of like a development of ametropia. So ametropia means how the refractive error is developed or developing. So I'm not going into the pathophysiology, those things, but on the basis of longitudinal studies. So there are four age category that we can take. So first category is the infancy and early childhood. That is basically the age group less than 5 years of age. Or in other terms, we can say that normally these childs are not going to school, regular school. So 3 or 4 years, still child is in the nursery class. 5 is the KG. So 6 years is the age from where the regular schooling start. So in that age group, so normally it has been seen in the study, there is a wide distribution of refractive errors. So within this age group, you will see a lot of different refractive error. Some might be having plus, some might be having minus, and almost everyone, like 99% children, would be having certain amount of astigmatism. And gradually, all those refractive error that we found in our refraction, so gradually, by the child reach to the age of 5 or 6 years, so most of the in normal children, they reach to the emetropia stage. So the second category we can say is childhood to adolescence. So that is basically 5 years to the middle or late teen years. So this is basically school going age. And this is the age where the loss of longitudinal studies have shown that so if a children having a plus 1.5 dioptria till this diopter of hyperopia till this age, so there are a lot of studies which has been shown that the child probably would be remain hyperopic by the age of 13 or 14 years of age. And majority of the children with plus zero point 0.5 to 1.25 refractive error by the age of 5 to 6 years. So uh, by the age, by their teen age, so by the time they will reaching 13 or 14 years of age, they will be shifted to emetropic condition. And most children who enter school with a refraction of like emetropia, so like children of 5 year of age or 6 year of age, and when we do refraction and we found no refractive error or very low refractive, hyperopic refractive error, low means less than 0.5 refractive error. So normally these kind of children, when by the time they will reach to their teenage years, so they mostly develop some amount of myopia, very low myopia. And children who are myopic by the age of 5 to 6 years, so eventually they will become more myopic by the age they will reach in their teenagers. teenage category. So this is how the like emmetropia developed in this school going age group. Now coming to our third category, that is adulthood. So this is one category that is basically the teen years age. So teen years, so teenager years are basically 13 to 18, 19, we can say teen years. So we can take 18 to 14 years of age. So normally in this age group, normally the refraction remain stable. So if a person is aging 16 or 17 years or 18 years of age, so there is a very high chance that they will not develop any kind of refractive error by the age 40 years. After 40 years, obviously they will be having some presbyopic additions. But the vast majority of patients in this age, 21 to 34-year-old range, had refractive rates of 0 or very close to 0. So even if they have refractive errors, so it is very unlikely to progress in this age, 21 to 34-year category. And longitudinal studies have been shown that the mean annual change in this age group is about only 0.05 diopter, that is almost negligible. And our the fourth age group is 40 and above 40. So if you see the development of emmetropia in this age group, so there we see the trends of hyperopia. So if you are refracting a patient age 40, 45, 50, so most often you will find they are having some hyperopic error. Even those patients who are not having any refractive error, so they also develop hyperopia after 40 years of age. The reason being the change in the lens refractive index. So the mean spherical equivalent refractive error increases in plus from 40 years of age to the mid 60s, after which it decreases. After 60, again there would be shift to myopia because of the nuclear sclerosis or because of the cataract. So this is how like normal overview. Okay, so this is the same. So normal overview of the emmetropia. So very like on the top, if you see how the refractive error we see in different 4 age groups. Now coming to the topic of the day, that is basically refraction. So first we'll discuss very basics of refraction that I still feel that most of us are not doing correctly, the basics things. So that I would be discussing again, it is a kind of a review class. So first, how will you ensure that your refraction should be very accurate? So one thing is the technique. Your technique should be correct. So that you learn by your the practice. The more practice you will do, the more you will learn. But the other thing that contribute to the accuracy is the area of retina that you are refracting. So can anyone tell me that when we are doing the refraction, so from which layer of retina we are getting back the reflex? There are 10 layers. So from which layer of retina we are getting back the reflex?
Retinal pigmented epithelium, RP.
Okay, so it is a RP layer. So an RP layer, and that RP layer you need to refract at the macular region. So if you are refracting some area other than this macular region, so you're not going to get the correct refractive error. Most of the time, we will end up by getting unwanted or slender. So patient would not be having slender, but we would be getting some slender because we are not refracting the macula. So and the light rays which are reflecting back from the RP layer, they will be the brightest one. So we need to refract. So how will we ensure that we are refracting actually the macular area? So we need to always maintain the correct position. Your eye position and patient position is one area. And the second thing is that how much you are deviating from the patient eye. So one of the basic thing that has been explained in optometry school that the ideal way of doing refraction is do right eye from patient right eye from your right eye, patient left eye from your left eye. So that way is one of the like very basic way to ensuring that you are refracting this area. And other thing is that maintaining a proper like visual axis. So patient eye axis and your refraction axis, it should not be too much deviation. And the second is the correct working distance. So that also contribute to the your accuracy of objective refractions. So this is the basic thing that we always explain everyone, that you need to maintain your best walking distance. So most of the time, we see that a senior has done the refraction and they have subtracted their working distance 2 diopter or 1.5 diopter. And we also start using the same thing. That might not be correct because our working distance can be different. So it is good idea to know your working distance and do the deduction from the final refractive error according to your working distance. And the second is the concept of far point or end point. So far point is what? Anyone, any intern can tell me what do you understand with a far point? What is far point? Intern, fellow, anyone?
Hello, sir.
Yes.
Sir, actually, far point is the farthest point that a person can see clearly with the minimum effort of accommodation.
Without using any accommodation. So far point is that point whether we can see without using the maximum, the farthest distance that we can see without using any amount of accommodation. So for any emmetropic, we say the far point is at infinity. So we can see till the infinity. So that is our far point. For hyperopic, it is behind the eye. For myopic, it is in front of the eye. Means it is like, depending on the myopia, it could be for 50 centimeter, 100 centimeter, 200 centimeters. It is in front of the eye. So we need to put the far point. So when we are doing the refractions, our aim is that if a patient is hyperopia or a myopia, we should put this far point of the patient to the infinity so that we can make them emmetropic by giving the addition. So how will we do that? So I'm not going into the like objective refraction. Objective refraction we already discussed. So in objective refraction, the basic thing is that your your technique of doing refraction is one thing, and how you're maintaining the accuracy. So working distance is one of the important factor that need to be considered. And the second thing is that which area of retina you are refracting. So if patient is seeing in a primary position very straight, so most often if we are seeing a straight and we are doing refraction, so then if patient is seeing a straight, so most often it is likely that we are refracting the macular area. But if the patient is not seeing a straight, so we are not refracting the macular area, we are refracting some other area. So that is a part of objective refraction. Now in subjective refraction, there is a two technique, monoocular and binocular subjective refraction. Most often we do the monoocular subjective refraction. So monoocular subjective refraction is that where we occlude one eye and where we find out the acceptance of the eye in which we are giving the acceptance. So the other eye is totally occluded. So that is monoocular subjective refraction. So monoocular subjective refraction can be done, or normally we do, but the problem with the monoocular subjective refraction is the accommodation of the occluded eye is unstable. So there are conditions where monoocular subjective refraction is not preferable, and there are conditions where monoocular subjective refraction can be done, and there would be no any issue with monoocular subjective refraction. So like I have mentioned, like all this condition where binocular subjective refraction would be a better way of doing subjective refraction. So binocular subjective refraction is what? It is basically a monocular subjective refraction under binocular condition. Means what is the means the point is that the patient is seeing with both eyes. So you are not occluding one eye and then we are doing the acceptance. So patient is seeing with the both eyes, so right eye and left eye, though we are giving the acceptance only in the right eye, and similarly the vice versa. So there is a different technique of doing binocular subjective refraction. Means how can you do that? So one way of doing is that you put something between both eyes by which the both eyes are not able to fuse the image. So that we can do with the help of phoropter. So that we do not use phoropter. So other technique of doing binocular subjective refraction is you used a polarizer. So polarizer is also, we do not use. Polarizer is two kinds. One is lens polarizer, or your target is polarizing target. So that is also not very practical to do in the clinics. So the simplest way of doing binocular subjective refraction is the blurring or fogging. So fog the other eye, that we are not doing the acceptance. So suppose there is a right eye and left eye, and I am giving the acceptance, or I am trying to find out the acceptance for the right eye. So what I will do, I will not occlude the left eye, I will blur the left eye. I will blur the image of the left eye, not blur so much that nothing is visible. I will blur so much that the patient left eye can appreciate the words outlines. They will not able to exactly read the lines, read the letters, but they will able to appreciate that something is written there. So that much occlusion or fogging you need to done in cases of binocular subjective refraction. So it is the same as a monocular, except that both eyes are open, it is unoccluded, and views a common target. So these are some of the indications. I don't know how many of us are doing this binocular subjective refraction, and I feel that refraction is one area where we still not focus as much as we need to focus. Most of the time we focus too much on objective refraction, but I feel that subjective refraction is one area where we need more our focusing, more learning in this way, because objective refraction, there is a number of way by which we can get a good objective refraction. One is your retinoscopy, other is AR is there. But if we do not know a good subjective refraction, then there is an issue. So these are some of the indications like hyperopic anisometropia. So an asometropia with that is hyperopic, those kind of refractive error. So the subjective refraction must be done in binocular condition. Antimetropia, so one eye is myopia, another is hypermetropia. Latent hyperopia, pseudomyopia, unilateral amblyopia, unilateral reduced acuity due to eye disease condition, significant cyclophorias, and latent nystagmus. So what I will suggest to each one of you that read more about this binocular subjective refraction, read more like what is the correct technique of doing binocular subjective refraction, and then at least start doing that one patient each day. So by the 1 month end, you will be having a good confidence while doing binocular subjective refraction. Then monocular subjective refraction. So monocular subjective refraction, we all know we are doing it very commonly. So this is the starting point. So starting point would be objective refraction or patient PGP or AR values. And we control the accommodation by the fogging. So we fog, and then if there is an astigmatic correction. So astigmatic correction we give after best spherical correction. Best spherical correction we get from fogging only. And then for binocular balancing, we spherical equalization or control of accommodation, we need to do binocular balancing. This is the monocular. So even if you are doing the monocular subjective refraction, so binocular balancing should be done. So this is one of the picture which is depicting how to do this thing, binocular subjective refraction. So here what we do, so we are doing the refraction acceptance for the right eye. So left eye vision has been blurred with 0.75 diopter. You can use 1 diopter. The basic idea is that the patient can see the letters, but they can only see the outlines. But it should not be very much visible like other eye. So the one of the reason that why we want both eye to be seeing things, because this is the normal condition. This is how we see the thing. So in the real life situation, we see the things with both eyes, not one eye. And when we are doing this kind of acceptance, so the accommodation is in control. Otherwise, the accommodation can be fluctuating especially in cases of hypermetropic errors. So relaxing accommodation, we already have this discussion a lot. So there's a way of relaxing accommodation. One is the optical method is by doing fogging, and a pharmacological method is doing by dilation with the cycloplegic drugs. So what happened? So why it is very important to rest accommodation? It's very important. So see, even if you are discussing the monocular or binocular subjective refractions, so there also the accommodation is the factor that force us to do the binocular subjective refraction in certain condition. So what happens when the patient is so if the patient is a hyperopic, so by the using of accommodation, they can correct. If the myopia, in cases of myopia, or myopia could be happen if there is a excessive accommodation. So simply fogging, already it has been discussed what we do in fogging. I'm not going into that. So this is the procedure we just, so this is one way you can do that. Whatever the refractive error you are getting, just add up your walking distance in your objective finding, and then add plus power in 0.25 diopter to blur, and then de-blur. So again, not going into that. Hyperopic fogging, high plus to low plus, aim is the maximum plus maximum visual acuity. So there are a lot of confusion. Do we need to do fogging in the myopia also? So actually the myopic patient are already fogged. Means when we are doing the fogging, what is the aim? The distance vision is blurred. So for myopic, the distance vision is already blurred. So we do not need to do fogging for them. But we need to do defogging, means we need to make their vision clear. So suppose you are getting in refractive error -4 diopter myopia. So while doing the acceptance, we'll not directly put -3.5 or -3.75 and we'll ask that read the chart. So the way of doing is that if you're getting -4, start with -2. So this is how you're defogging, because their vision is already fogged. So put -2, then put -2.25, then 2.5, then 2.75, then 3, and like this. So the aim is that the minimum minus by which the patient getting the maximum visual acuity. So that should be given. So when should I do fog? This is the question. So do we need to fog in each and every patient? So yes, all myopes, as I already said, myopes are already fogged. So you do not need to put an extra lens to make them fog. They are already fogged. Only thing you have to do, you have to defog. But hyperops, they are not fogged. You have to make them their vision blurred because they have active accommodation. So you need a plus lens. So what happens when you are putting a plus lens, you are making them myopic. So if your person is having a 3 diopter of hyperopia, and what happens if you put a +5 diopter in front of their eyes? So the light rays will be focusing more in front of the eye. So by putting more plus, we are basically making them myopes, and that's how they fog for distance. But there are certain conditions where we can avoid fogging, like a person who is a high plus number and they are already using those numbers. It is that person is not first time wearer. So that person is using their glasses last 2 years, 3 years. So that person we do not need to do a fog again because they already have adapted to their glasses. If there is a significant change in a new number, suppose they are using +4, and in a new refraction you are getting +6 or +7, then you might need to think of fogging while doing the acceptance. But if you are getting only change about 0.5 or +1 diopter, you do not need to do a fogging because they are already well adapted to their glasses and their accommodation. Age is one factor. So a person above 40 years of age, again, you do not need to do fogging. Less than 40 years of age, of course, you need to do fogging. And symptoms. Someone who is having asthenopic symptoms, even after 40 years of age, having plus number or having asthenopic symptoms, you need to do fogging. It is a good idea to do a fogging. But someone who's having even 20 years, 24 years of age, having +2 diopter of refractive error hyperopia, and they do not have any symptoms. So ideally, we do not need to give them any fogging because you don't want to give any prescription to them. So this is one question and I want answer from interns first, then fellow. So this is the condition. So this is a 10-year-old refractive error, both eye +3, unaided visual acuity 20/20. They have no symptoms, no squinting, and no history of previous glasses. So do we need to give glasses in this kind of 10-year-old boy with +3 diopter refractive error? Boy or girl? Fast. Give me your answer fast. I do not have much time. मेरी आवाज आ रही है सब तक नहीं आ रही है तो I am audible or not audible?
Yes, sir. You are
Because
audible.
dry.
Yes. So what is the answer?
I just want to confirm this +3 is dry or
This +3 is the acceptance. Forget about dilated or this is the final acceptance. Okay, so no
So
answer.
we will prescribe this
Yes,
power.
we will prescribe.
Hello, sir.
Yes, Manish.
Sir, I am Kuldeep. Sir,
Yes, Kuldeep.
we should prescribe undercorrected power.
Okay, so if I am seeing this patient, I will not prescribe anything because the child is not having any symptoms, and they are not having any squint, and they are not any history of previous glassware. I would thinking of prescribing if they are having any symptoms, asthenotic symptoms or any sign of squint. I will assume that they would have a good reserve of accommodation by which the patient is able to do their work perfectly fine. What I would be interested in doing is to keep that person under watch. So I would like to call that person again after 6 months and again want to repeat the refraction, and again I wanted to see if there is any squint or not, latent squint or manifest squint. So if there is no symptom, no signs of squint, and no history of any glasses wearer in the past, so probably this is a good idea to do not give glasses, because what is the reason of giving glasses here? The patient is having good visual acuity, not having any symptoms. So why we wanted to put a glass there? Now this is the second case. Again, the 10-year-old, again the same refractive error acceptance. And again, the visual acuity is not 20/20, it is 20/40. And the basic three criteria is the same: no symptoms, no sign of squint, no previous glass wear. So what you will do in this case? Answer from anyone, faculties, fellows, interns. Probably from the fellows, because you people are doing independent OPD. Yes, Dr. Arun. Yes, Gopuram. Ram Gopal sir.
Yes, sir. Very funny. This kind of cases, because of vision is 20/40, so we should be give the glasses and with patching because of vision is 20/40. If in this case you will not give the glasses, the patient will be go in the amblyopia.
Yeah, correct. So probably I will give glasses, and I will start with the fogging. Of course, there would be cycloplegic refraction, but I'm not interested in giving the cycloplegic refraction. I will do the subjective refraction, and I will try to see that how much patient is accepting under good fogging, under the fog. And whatever the patient is accepting under the fog, I will give that number to the patient. Okay, so now this is the third case. Again, the age, refractive error, and visual acuity is same. Now here the thing is that patient is having asthenotic symptoms. So there again, the good idea is to give the glasses because the asthenotic symptoms is probably because of this refractive error, because we know that hyperopic refractive error are one of the leading causes of asthenotic symptoms. Again, I will fog and I will see whatever the refractive error is coming under fogging, what the patient is acceptance, and I will give that number. I will not go by cyclorefraction. Cyclorefraction I wanted to do, I will definitely do to see that how much latent hyperopia component is there. But my final acceptance power would be on the basis of patient acceptance under subjective refraction. And this is my last example. 10-year-old, both eye +3, unaided visual acuity, same 20/40. Asthenotic symptoms are there. There are sign of squint, intermittent squint was also there, and there is no history of previous glass wear. So I want this answer from pediatric optoms. Maybe it's Rusty.
Hello.
Anyone? Yes.
Sir. Squint is intermittent XT or intermittent ET?
It would be 18 only in plus. Mostly
Okay.
it would be 80.
So, sir, in that condition, I'll give full correction. I'll give full correction because if you will not give full correction, that it's converted into the constant. So I'll give the full cycloplegic correction and give also patching also.
Yes, good.
So the reason is
patching. I will not go directly. Okay, you can go directly. I will not go to the patching directly because the patient is not any history of previous glassware. So what I would do, I would do the cycloplegic refraction. I will not do any fogging because patient is having a squint, so I do not need to do fogging because I have to give the full cycloplegic correction. So fogging here is not of much importance. I will give. So that would be my plan.
Sir, firstly, I'll give the glasses for 6 weeks. Then after 6 weeks, if it is vision will improve, then I'll go ahead with the glasses. If it is vision will not improve, then I'll give the patching.
Yes. Fine. So till here, anyone is having any question or any comment regarding the 4 cases that we have discussed just right now? I think.
Hello.
Yes.
Hello, sir. I have written one book.
That will take in the end regarding these 4 cases. Okay, fine. I think we don't have. So the next big confusion is that how much should I fog? So again, there is a lot of confusion among the optometrists regarding. See, the fogging is the basic rule everyone should understand. It is the same. So whatever the patient visual acuity is there, you should fog that. If the patient visual acuity is 20/60, so after fogging the visual acuity is up to 2 lines above to that. Means it is up to 20/60 means it should be 20/100 or 20/80. 20/100 would be probably. So you need to put a plus lens by which the patient would be having, if the patient is having visual acuity 20/80, best visual acuity, presented visual acuity, with the fog lens, you wanted to have a visual acuity 20/100 and then you will defog. So that's how much you need to do fog. It is not that if a patient is having very high refractive error, very high plus number, so you need to do a very high fogging. So if someone is having, or patient is a very young age, so child is of 5 years of age, having 5 diopter of refractive error +5. So normally what I have seen the people do, what they do, they put a +10 diopter for fog. That is not the way to do fogging. What you are doing, you are totally blocking the patient vision, and that would actually lead to more activation of accommodation rather than resting the accommodation. So you need to put a lens only that two lines, the patient presenting visual acuity, by that the patient 2-line vision should be blurred above to that. So age, refractive error, asthmatic symptom and deviation, that the debate could be on that how much time you need to fog. So you put a lens and you can start suddenly defogging, or you should wait for some time. So on which you can have a debate, you can have your own clinical experience, but the way of doing fogging is the same. You do not need to put a very high plus number to fog. The duration could be debatable. And last point should be remember, over fogging should not be done in any case because it will again reactivate accommodation rather than resting it. So dry acceptance, cyclorefraction values are the ideal values because we have controlled the accommodation by the help of pharmacological effect, but not always possible. And some of the time, whatever the value you are getting in the cyclorefraction, even after doing the tonic compensation, the patient would be having adaptation problem, especially in the adults patient or children. So that's why you need a dry acceptance, very compulsory. If patient do not have a squint, you need to have a dry acceptance. And dry acceptance will basically give you an idea that how much number you need to prescribe to the patient. And squint is one of the biggest deciding factor. If the patient is having a squint, so no debate, you have to give the full correction on the basis of cycloplegic refraction. So again, example, you get a +3 diopter in a dry flash, unaided visual acuity 20/20, fog lens, +4.5 diopter 20/100. So you started decreasing burst power, and this is how it got here. So when you started defogging, so with +2.5, patient is saying 20/20, +2 is also saying 20/20, +1.75, +1.5. So which number will give to the patient according to our fogging rule among the 4 power? Because by all, the patient visual acuity 20/20, and probably the patient will say that 1.5 is better than 2.5. But what number we need to give them?
Sir, +2.50.
So maximum plus maximum visual acuity. So this is the rule. Okay, but that is the rule, but that is not the thumb rule. So in medical science, there is a no thumb rule. So you need to also consider about these things like patient refractive error, patient age, patient symptoms. If no squint, then we also can give a slightly reduced fog. So it is not like that always that maximum plus maximum visual acuity. So depending upon if it is not a very high refractive error or not a refractive error, something that can cause asthenopic symptoms, then you can go slightly reduced fog. If patient is not a very young child, then also you can go to the slightly reduced fog. The patient is not very asymptomatic, patient is very less symptoms, then also you do not need to give the +2.5, maybe +1.5 also work. And if no squint. So there are a lot of factors that come into play. So what happens if you are not doing fogging? If you are not doing fogging in case of hyperopia, you are not giving them sufficient plus power that they might require. And if you are not doing fogging in the case of myopia, myopic refractive error, you are giving them high minus. So both are not desirable conditions. So now coming to the troubleshooting and difficulties during retinoscopy. So when you're doing an objective retinoscopy, there are some difficulties on how to take care of them. So before going into that, I think we'll stop here and take some questions, because after that, this topic is different. So I will take this question that has been put by Shoaib. If a patient 42-year-old having +3 diopter in dry refraction and no history of using glasses or having ocular pain, should we fog and patient or not? The patient 42-year-old having +3 in dry refraction. Okay, so good question. So what I will do, I will see the patient is 42-year-old having +3 diopter in dry refraction and no history of using glasses. Or having, so there are no asthenopic symptoms, right? And plus 42 year of age, they are normally having so little amount of amplitude of accommodation. So anyhow, they do not have so much accommodation, where the excessive accommodation could be one of the concerning point. So probably I will not do the fogging in a way I will do in a young child, but definitely I will not directly say +3. So I will not directly give them +3. So what I will do, so I will start with a like +4, +5, then I will slightly reduce the power. So in a way, you can say that I am fogging it. Only reason is because then the patient is not wearing glasses in the past. Though this situation is very unlikely, a 42-year-old having +3 diopter. So it is very unlikely that they are not wearing any glasses. But if any patient is coming in this kind of, so to answer your question, yes, I will fog. I will do the final acceptance according to the fogging. And then I will give the addition. Usually Helen is having usually patient used to have very much difficulty in accepting the fog value. After some time they come back and tell my vision is not good like that. How do we avoid that? Okay. So Helen, this is the problem happen when you give the lenses fogged power in a very young, in adult patients, not a very young patient. So a patient 18 years or 20 years of age, they are having +4 or +3. And what we did fogging, like this example I am showing here. And according to this example, what our rule is saying that maximum plus maximum visual acuity. So we tend to give this number +2.5. But a person who is having 18 or 20 years of age, they are kind of adapted to their accommodative demand. So suddenly they are not going to relax their accommodation because their eyes are used to of having using so much of accommodation since last 18 years. If the patient is 18 years of age, so suddenly if you want to give adequate plus numbers so that they can rest their accommodation, that is not going to happen. And that's why they come back and they will say that the glasses that you have given me is not working. So what you need to do, you need to also check for if there is any astronomic symptoms. So if there is astronomic symptoms, so I will go by this rule only, maximum plus maximum visual acuity. But with that, I will do a very good counseling. I will say that you have this number since so many years, your eyes are not used to of relaxing your accommodation or your abnormal eyes action in their language so that they can understand. So I am giving this number. By this number, your astronomic symptoms will go gradually. But you need to use it like in a phase manner. Like don't start wearing 12 or 14 hours from the first day. So do with like 2 hours for 2-3 days, then 4 hours for next 4-5 days. So like this. And one of the very important thing you can start doing in this kind of patient, adult patient, tell them that at least use these glasses while at the time of reading, because that is the time when they are having most of the astronomic symptoms. Because at the time of reading, they need to accommodate more. So at least use these glasses at the time of reading or doing near work. If you are not using it for distance, that is fine for now, but at least start doing with your near work. So you need to do a good counseling, and you need to also think of other factor also. And can you elaborate the stopping point one more time? What is stopping point, Helen? Can you ask?
No, sir, you just elaborated. Thank you.
If cylindrical value component is there in refractory, how do we do fogging in a person? So see, cylindrical is nothing to do with the fogging. Means you have to, fogging we do for the sphere. So cylindrical is not an issue. So whatever the cylindrical number is there, patient is going to accept. In cylindrical, you don't need to do any fogging.
Sir, I'm thinking that if there is cylindrical component, because patient will not see 20/20 if cylindrical component.
You need to give the full cylinder. If it is the first time wearer, then you need to reduce the cylinder also. But if the patient is not first time wearer, so then you can give the whatever the cylinder the patient is getting.
No,
but
sir, while we are doing fogging, we will put the cylindrical value from the beginning, or like we will do it at the end point of our spherical value.
No. First, you find out the best sphere. So from the spherical number by which the patient is getting the maximum visual acuity. Okay, and then you put the cylindrical, whatever you have got in your refraction. Okay, so suppose at the very starting you have put it, and by that time the patient is reaching 20/80 line, and from that, whatever, if you are even changing, reducing or increasing the sphere power, the patient is not saying that not good, I am not seeing anything better, then you probably need to put the cylindrical number also, whatever you have got. But first you have to start with your spherical number. See, these all things are very important plus number. Myopic patients normally do not have this issue. So whatever I am saying, you need to consider these points in a plus number. Okay. Don't apply these all things in a like normal patient, very low refractive error, -3, -4. Normally, myopic patient, you will not having any issue. This all issue will come in a hyperopic patients only.
Thank you, sir.
If a patient is having refraction of +2 diopter and unaided visual acuity is 20/20 and patient complaining of astronomic symptoms, then how we can deal with the patient? Give full correction under. So +2 diopter. So first thing here, so again, means you need to see the patient age also. +2 diopter, if a patient is 6 years of age, so that patient probably having +4, probably having +6 or +7, because they are having so much strong accommodation. So in this kind of condition, first thing to do is to do a cyclorefraction. That is the rule. You need to do cyclorefraction in each patient who is having plus number, if the patient is less than 40 years of age. So do that in all patients, irrespective of your clinic, whether you are in pediatric or not pediatric. If the patient is less than 40 years of age, patient is having hyperopic refractive error, and especially if the patient is not using any glasses, then do the cycloplegic refraction. So that will give you the correct idea. But in this +2, when you are doing the subjective refraction, you need to do fogging. So in this +2, that is manifest what the patient is accepting. And give full correction under correction is not so easy to decide only on basis of that. So for this kind of so little amount of hypermetropia, and patient is having astronomic symptoms also, so definitely they would be having a high amount of latent component. So age is 6 years, so you need to do like cycloplegic refraction. And on the basis of that, you would be deciding under correction, over correction. Any condition we should not follow the rule maximum plus maximum vision. I already have explained just now when you should not follow. It is not like it you should not follow. You need to means. So the rule is that maximum plus maximum vision. But you also need to consider about this factor: patient age, patient symptoms, patient squint. Okay. Any condition where we should not follow the rule maximum. Okay, if patient is having dry retina value of +4 and under fogging, that patient is accepting +2. And in cyclo, we are getting +6. Should we fully correct dry refraction, or we should under correct it? And if you're doing under correction, what is? Okay, so I will not see, there is not any guidelines. There are no guideline is only in for the pediatric population. For adult, there is no guideline. Okay, you need to apply some your basic learnings, whatever you have learned, especially in cases of plus. You need to apply your all learning related to accommodation, convergence, everything, and astronomic symptoms. So in like this case, patient is 35 years of age, already having dry retinal +4, and under fogging patient is accepting +2, and cyclo getting +6. So I will probably, and the patient is not wearing glasses till now, so I will probably go with +2, because this +4 patient is not accepting, because that's why you got +2. +6 only give you that how much patient is having latent component. So latent component is about +4 diopter patient is having latent component. That is quite high for the age of 35 years of patient. But if the patient has not weared glasses first time, then I will go with +2. I will counsel the patient that you have this much refractive error, but I am giving you less number, and gradually in 3 months or 6 months time, we will increase your number so that you may not have any astronomic symptoms in future, or you have a good visual acuity for distance and near also. So what I think I stop here only. I will not go into the this part. Maybe in troubleshooting, maybe we can discuss in some other class, because this is again lengthy. So any more question?